The objectives for today's webinar are to analyze the challenges in building and sustaining community academic research partnerships, evaluate a model for building a community academic research partnership, and to appraise lessons learned, resources, and checklists for building and sustaining community academia research partnerships. We will begin today's webinar with a poll question. What is the top challenge in community academic partnerships to address health disparities?
Great. Thank you so much, Sherilyn, and thank you for sharing just a bit of your day with Lashawn and I. So before we dig in, we really thought this question was an important conversation starter as we share our model, that we're both honored to be able to experience, contribute to, and then help to scale over time. But we wanted to start with this question about just what challenges you may see when we think about community academic partnerships to address health disparities. So just to kind of reiterate what we're seeing here, the first, it looks like we have more people who selected the first option, and that's that academics are not traditionally trained to share or collaborate with non-academic experts. And then, so 53% of you, almost 54% of you shared that perspective, that that was the top challenge. And that was followed by the last bullet, that the benefits of community academic partnerships are not well understood, right? And so, of course, that's changing as people continue to weigh in. So we want to be able to talk a little bit about each of these. And just as we frame this discussion, speaking as one who is in academia, the truth is that the first option certainly is right. Most academics are not trained to share or collaborate with non-academic experts. Even those of us who might be in the social behavioral sciences or say we're doing community engaged work, academia is traditionally designed to train you to think that you are the expert, right? Whether it's an MD or a PhD. So this whole culture of sharing and collaborating with those who are not in academia is something that, you know, we're just learning. And certainly CBPR, or community engaged research, is really leading the charge in changing that tradition. So that's true. That certainly is a challenge. The second is that community members have less experience being positioned as leaders like MDs and PhDs. That certainly, depending on the lens you look through, is also a reality. Not only are they not necessarily positioned as leaders or experts, but the healthcare system and the research system has been designed for the average neighborhood resident to feel that doctor knows best. And so working in partnership, genuine partnerships, as the ones we're just going to be describing, is a different approach. You know, for those who in their lifetime have not been positioned as an equal partner. And this means not just being a token one at the table, but actually governing or strategically advising research and other health initiatives in co-creation with academics. The third is that community engaged research is still gaining respect and traction, and this is true as well. So this also is true, depending on the lens you look through. The truth is that more and more, probably over the past 10 to 15 years, there is a requirement in a lot of grants to have some type of community advisory board. And now we're seeing it not just for grants that say that they're doing community engaged or translational research, but even grants now that include basic scientists. That is just turning in terms of the acknowledgement of the importance of community voice. And so it is still maturing. The field is still maturing in recognizing that. So that certainly is a challenge and a reality. And then the benefits of partnership are not well understood. Oftentimes people think that community engaged partnerships are just kumbaya, sitting and talking, with no outcomes beyond that. And what we want to do is change that perception that we can have high touch, high rigor in terms of research, and these things can work together to create healthier communities, community transformation, better health outcomes, among many other things. So all of these in reality are challenges, but how you respond, it helps us to kind of get a sense of what this community of participants today feel are the issues, but all of them are important challenges that we want to talk through how we've navigated them. So just to kind of give you a bit of history and background in terms of the lenses that we look through by way of the partnership that Lashawn and I represent with many others who co-labor with us, is that of the Morehouse School of Medicine Prevention Research Center. And so our theme is risk reduction and early detection in African American and other minority communities, and we call it a coalition for prevention research. I can say it now, that theme comes off of my tongue very easily, but well before Lashawn and I became members of this important work, community and academic partners were very thoughtful about this theme. Every word was by design. The notion of talking not just about early detection, but also risk reduction, and thinking about not only the realities of African Americans in Metro Atlanta, but the fact that back in 1997 and 8, there was a lot of gentrification that was happening in Metro Atlanta that made leaders at that time recognize that we had to include the reality of other minority communities when we thought about what the work of this center would address. I think all of us are very aware that when we think about minority communities, we are not only thinking about race and ethnicity, but also layered on top of that includes otherness that translates to health disparity populations. You know, the terms change, but the definitions and the respect for what those things mean certainly should stay the same. And that is that whether you call priority populations, minority communities, or health disparity populations, as NIH does, we know that they are those populations that typically experience greater loss of life, compromised quality of life, and many of the things that define that at the root have to do with less power historically, being marginalized, and then also having research and healthcare systems that have not been prepared to understand their needs. And so it really requires a collaborative approach that includes not just academics, but especially those priority populations to be advising and steering our work based on the lived experience. So health disparity populations right now represent those that are defined by race or ethnicity, gender, geography. So we know that there's a lot of nuances between rural and urban settings, populations that are defined by sexual orientation or identity, as well as immigrant status or disability status. So when we think of that, we want you to think about this very broadly in terms of where you live and lead, and think about how what we talk about might be relevant to you. So we were funded in 1998, but not knowing then how long we would be funded. So every 5 years, prevention research centers have the opportunity to reapply for funding through the Centers for Disease Control and Prevention. And PRCs are designed to house a core research project that CDC funds, but we're also supposed to do the work of training, communication, education, and the wraparound with all of that is community engagement for research that makes a difference. So we've been successful four times and are moving into our fifth time of being successful in being a prevention research infrastructure that also has leveraged partnerships and funding through many sources, both federal as well as private. So we function right now as one of 26 PRCs nationwide, funded by the Centers for Disease Control and Prevention. And so our mission is to advance scientific knowledge in the field of prevention for African American and other minority communities. And we want to disseminate and share this information such that it doesn't represent research that sits on a shelf or that's archived electronically, but we want to be able to share that so that it's actually implemented in communities of practice. And communities of practice mean in neighborhoods, but also in systems, whether they be health departments or clinics or other systems where researchers do their work. We want what we learn to actually change the way that work is done such that we can be responsive to what works based on community voice. So right now we have a core research project, that one project that CDC funds, among many, that's called a multi-method approach to STI and HIV prevention among urban minority youth. And that's what we submitted when we applied, the first part of that description. But in keeping with a community-led approach, the urban youth who are engaged in this project recoined it HAPPY, or the HIV/AIDS Prevention Program for Youth. And it's designed to really get ahead of the risks for risk, meaning that we know in the South that the incidence and prevalence of HIV is astronomically high and is an epidemic that we cannot ignore. And based on the feedback and the leadership of local leaders through our community coalition board, we decided that we wanted to really have youth engaged and at the helm of approaches to get ahead of the risk group, where we know there is one of the larger incidents of HIV and STIs, which is 18 to 25. So the youth who participate in HAPPY are ages 14 to 18, and they're doing amazing work that you can find out about through our website. We're also really pleased to have a project led by our Morehouse faculty in collaboration with Emory University that is designed to adapt a project called Uplift for Blacks with Epilepsy. There is a lot of stigma associated with mental health for minority communities, and epilepsy is one of those conditions that is exceptionally understudied and understood. And so Project Uplift is designed to dispel myths surrounding what epilepsy is and isn't, and then to see if Project Uplift actually works among African Americans or Blacks in Metro Atlanta. So that's just a bit of background on who we are. We have a number of other components of the center that we invite you to get to know and understand. You'll hear more about them through this webinar series. But today our focus really is on talking about this model, which is the wraparound for the research I described, among many others that you can find on our website. Our other aim is to train the next generation of whatever they want to be, from K all the way through to lifelong learners and leaders, on what effective community engaged research takes. And so you can see here through many of our partnerships through the CDC, like the summer opportunity in public health that attracts now about 250 students across the United States to think about a profession in public health. To the students, the medical students at Morehouse School of Medicine, among many others that come to us across the country, our intention is to show them what it takes to do this through practical experience with our Prevention Research Center. And for us, it is just as important after them seeing what this work takes, if they say that this is not necessarily what is aligned with my natural gifts. We think that's important and is not a bad thing. This work takes a certain type of dedication and skill set that is not for everyone. And just like I say, when I think about biostatistics, I appreciate it, I acknowledge it, and I know I need it, but I'm not a biostatistician. And it's just important with community engagement to know who knows how to do it and make sure that you have them as a part of your team. So, with that in mind, we'll transition to talk a little bit about why you're on the call, and that is to talk a bit about our model, which is the wraparound for all of the things that I've described, and that is community governance, not advice, in leading our Prevention Research Center. So I'll turn this over to Lashawn.
As you can see, we have really valued um, what community coalitions can look like, and we have embraced that in the structure of the Prevention Research Center and how we do our work. And so, as you look at this organizational chart, the Community Coalition Board really sits and governs the work that happens within the Prevention Research Center. And while that is a bit unique for some of this, most people have what's called a community advisory board. But this board, this board really looks at what does governance look like versus advisory boards, and how we believe this has strengthened the work that we do at the Prevention Research Center. Some of the uniqueness about the board, in which I am honored to chair the Community Coalition Board, is that always in the majority are the community residents. And so the community residents hold the leadership seats as well as the majority of the seats on the board, because it is important for us to be seen as senior partners. It's important for us to understand the research that's happening, but we become the trusted advisors that take this information back to our communities and to the residents that live within them. And so we want to ensure at all times that things that are done with us and for us are, are done in a way in which community really is represented. But the other uniqueness I think about our work at the Prevention Research Center is we also have academic institutions as well as agencies that are a part of our board. And so we're a policy-making entity. We set policies and oversee the research infrastructure. We really are clear that each project that comes before us really kind of embodies the community engaged research principles, and really thinking about how does community based participatory research plays an essential part in that. And, what is this trust that we need to continue to establish, sustain as we're doing this work collectively? One of the ways in which we are constantly in conversation about is really thinking about how our community values marry up with the core principles of community-based participatory research. And one of those principles, as you can see, it says that recognize community as a unit identity. And for us at members of the Community Coalition Board, that's really, having the right for self-determination. I think so many times individuals come to communities to conduct research, but it might not be the research in which those communities are interested in or really affect them immediately. And so, this right to have self-determination is really important, as well as if you look at the second principle that's displayed there, we want to be involved in this analysis and an interpretation, and that's really important. I'm sure there are many stories that can be told that people come in, they survey community, they take the data, no one understands or knows what happens to the data after the research is conducted. And what we really strive for in this partnership is that not only are community partners involved in the analysis and the interpretation, but how do we disseminate those results, and not just disseminate the results just as in a scholarly function, but then how do we make sure that community briefs are created so that the community can understand this has been the data that was received from the research, and this is kind of the end result that's happening here, so that community can make a more informed decision. I think another one of those key factors when thinking through some of the questions that you proposed earlier before the session started, I think this principle is really, really important, that knowledge and action for mutual benefit of all partners is really important. I cannot stress this probably more or enough, I should say, simply because I believe that communities have a lot of members that are really knowledgeable what's going on and have kind of a lot of insight. And sometimes I think researchers dismiss that because sometimes it may not be scientifically defined, or it may not be the most scholarly, but I think that there's some lessons that can be learned from both, as well as when the researcher comes, what information can they impart? What knowledge can they leave that enriches community and how have communities to be better off than how they left them? And so I think that leads to the fourth principle that's there, this co-learning and this empowerment that attends to social inequalities, I'm sorry. It's really important that we do that. And so every project that we try to work on, every project that comes for us for research, we're looking to see that that the projects meet these community values that we've outlined. And just for a few more, I think again, based on some of the questions that were proposed, how do you sustain these partnerships between community and academic? Partnerships have to last beyond the funding. If the only reason that the partnership was created was because there was a funding opportunity, and that's the only kind of sustaining grace, then when the funding goes out, the partnership fades. But if you're able to build a partnership with community, not funded based, but based upon community needs, and researchers kind of quest for opportunity to help to dispel some of the health disparities that are happening in some of our communities, then I think that those are the partnerships that will last and that can be sustained beyond just funding. When we thought about our work, Dr. Akintobi and I was thinking about the transition that has occurred through the life of the Prevention Research Center. And we wanted to just be able to kind of highlight a few of those kind of what we think pivotal moments that really has helped us in our partnership. And then really kind of how do we scale this model so that the Community Coalition Board and the way that we do our work can be one that can be replicated. And so you can see, as stated earlier, that the Prevention Research Center, the Coalition Board was started in 1988. And what ended up happening was, because of this group of individuals that have come together and that was very knowledgeable and have decided that research and how to implement research and using that data was important for some of the community issues that they were fighting, the Community Coalition Board was looked at as a community institutional review board. And those of you that are familiar with IRBs understand the importance of going through the IRB process, but think about that from a community's perspective, right? And how beneficial that can be when community is playing an essential role in helping to work through projects with investigators. And at that time, this was kind of a one-time opportunity for investigators or researchers to come before the Community Coalition Board around either community engagement or expertise or relationships, right? And to seek recommendations on how they can be able to employ their projects to be more successful. And there were a couple of projects, and Dr. Akintobi, you want to talk a little bit about kind of the project that occurred kind of doing that community IRB process?
During that time, yes. So these are just a couple of examples because we really want you to really get a sense of how some of this played out over time. So, we're very clear that, as Lashawn described, the reasons why researchers would come to present or share their work really varied. It ran the gamut. And we're clear that many of them were not necessarily thinking CBPR or community engagement when they came to present. But we always have had a process where if someone from Morehouse School of Medicine or beyond, which was frequently the case, they would speak with leadership of both the board and the center to kind of tell us a bit about what they were thinking. And in this case, with the Smart and Secure Children project, which was funded by the NIH. Its initial funding was through the NIH, and we'll talk a little bit about how that evolved. When the investigator first came to Dan Blumenthal, and I think it may have been you, Lashawn, or maybe Ms. Trammell, depending on whether you were the chair yet or not, but the grant had already been funded. They had already developed, for those of you who've written grants, developed the plan, the implementation strategy, which communities were going to be served, et cetera, et cetera. So this was a train that was already getting ready to run. But, as many of us know, the good news is you get the grant. The bad news is you get the grant. Now you have to go in there and look and see what you said you were going to do. This investigator was not connected to the Prevention Research Center, certainly had the intention of collaborating with community partners for this project that was designed to work with parents as role models and potential change agents in improving their children's health, right? So, long story short, the investigator had the prep meeting with the leadership of both the CCB as well as our faculty and presented the project. And basically, it was a presentation of this is what we are doing. Can you sign off? I was at that meeting, and I think, again, we were in different places then in terms of our leadership or engagement, Lashawn, but I think you were at that meeting too, right? And so since there's a delay, I'll keep going, and Lashawn, you can interrupt me. Okay, so there was an expectation, even with that fairly well-meaning researcher, that I've checked the box off of coming to this quote-unquote community IRB to tell them this is what I'm doing in the community that's in and around where the CCB residents live and lead. I can check that off the box, but that's not how it went. So Lashawn, maybe you can share some perspectives, and I'm just going to read back what this box says as you share your perspective. So again, this is a community IRB exchange where our community or research leader presents to the CCB to get community engagement expertise, which is ideal, recommendations, and sometimes it's more than that. We didn't put that on this slide, but sometimes they want an approval or a sign-off. So, Lashawn, maybe you can share just a bit about how that went.
Yeah, what became really apparent to the members of the Community Coalition Board during that time was that the one-time presentation or the request that after making a presentation to the Community Coalition Board wasn't sufficient information for us to be able to make an informed decision. And specifically, this investigator got a bit frustrated because I'm not quite sure if they understood the breadth and depth of the members that were serving on the Community Coalition Board. But they started asking questions. I mean, individuals like myself who have written many grants and have run several nonprofit organizations understand kind of, what were the metrics that were used and what are the outcomes that you said that you're going to achieve, and kind of what were the budget implications that were around that. And that became very challenging for the researcher because they hadn't been challenged in that way to share that much information to get community support. And after that, it became very clear for the Community Coalition Board that we needed to incorporate more steps to ensure that when investigators and researchers were coming to the Community Coalition Board for presentations or for recommendations and for letters of support, that more that more information was needed. And so we formalized the process around creating a project review committee that said, you know, you needed to give the Community Coalition Board sometimes 30, 45 days prior to you getting ready to submit an application, and that there was a group of there's a members of the Community Coalition Board can form a project review committee and work with the investigators so they can kind of ask those questions up front, and so that by the time the presentation happens, it's a lot more clear around what are the benefits to community regarding the research, where were there opportunities for more collaborative partnerships, so that if there is a role that a stronger role that community can play, that was outlined. And if you were looking for support, how do we play an essential role in that, ensuring that this project is successful? And so that process, I think, did two things, right? It allowed more informed presentations, but also I think it helped to weed out those investigators and researchers that really didn't want to embrace kind of CBPR principles or this community engaged process, right? Because they didn't want to go through this kind of conversation with community. They wanted to keep research to themselves. And so it started to weed out those individuals that really weren't concerned about community-based or community research projects. And so after doing that, what we started to realize is that Community Coalition Board was reviewing projects prior to submittal, but it was almost the same effect that was happening that I described earlier that happens in communities. People come in, they survey, they take the data back, they get the research, and you never hear anything else. Well, we started wondering, we, kind of signed off on quite a few projects. What's happening with these projects? How do we play a role in it? How do we know that they're successful? We put our name on them. And so, how do we ensure that these projects are really doing what they said they were going to do and benefiting community? And it is through this process that we decided that we needed to create kind of a project review committee post funding, right? After the research has been funded and and is on its way. And so it allowed us to create what we now call community engaged research committees that allow for members of the Community Coalition Board and others to serve to help think through what the implementation strategy looks like. How do you launch this, and what relationships are needed with community in order for your project to be successful? How do you sustain this community engagement over time? And there was a project that was brought to us that was funded that really allowed us to pilot this process, which is now being replicated. The process is being replicated in other forms that we'll share with you today. And so, Dr. Akintobi, if you want to tell us a little bit about the Center of Excellence in Health Disparities.
So, the Center for Excellence on Health Disparities, we affectionately called it the P20 project because the funding that we got through NIH included in its title or its description P20. And so we got this developmental center that's similar to the Prevention Research Center, has a training core, has a biostats core or an evaluation core, etc. But it included 3 full-scale research projects. Now, just so we're clear, the P20 was not housed within the Prevention Research Center, but because all 3 projects had a community component, we were written in to lead the community engagement core, which was just like the biostatistics core, a required core of this grant. And initially, the intent was that each of the PIs, or the leads for the research, would come and present to the PRC that was known for having this community IRB. But that evolved because, as Lashawn described, we had already seen over time that people, the word was out, the secret was out, and researchers and others were coming to us regularly, but we were not really fostering an understanding that a relationship beyond coming to the CCB is required to actually have this stick. And so I really believe it was your brainchild, Lashawn, to have this community engaged research committee model really be grown or seeded through the P20 project. So as each of the PIs of these three projects, one was focused on HIV among women in rural Georgia, another was focused on another evolution of the Smart and Secure Parenting Project as they evolved, and then the third was focused on the effects of secondhand smoking among children. And so those projects did initially come and present to the board, but then we invited members of the CCB who either had organizations with this emphasis or had a unique passion for it to compose these three member teams that would work with each of these projects for the duration of their project funding. The intention there was to always have an odd number, so 3 was by design, such that of the 3 members that met quarterly with each research lead and their team, 2 of those, the majority, would have to be community residents. Mm-hmm. And so that happened for the duration of each of those projects. They had their challenges in adapting because they weren't necessarily thinking of a CERC committee when they wrote their proposals, but there were a lot of important lessons learned along the way. I'm going to pong it back to you, Lashawn. I know our time is getting short, but hopefully that was a fair description of that iteration of the Center of Excellence and the P20 as we've evolved over time.
Sure. And so lastly, for this slide, there are roles in which Community Coalition Board has been presented. And so it's not necessarily a funding, but because of the relationships and because of the strength and the breadth and depth of the knowledge base within the Community Coalition Board, we have served as advisories to other projects. And one of those great projects that isn't housed within the Prevention Research Center, but it really aligns with some of our goals and objectives is the Moyo project. That is, you want to talk about that really quickly?
For, what is mine is yours, and that together we co-create. Hopefully Sherilyn can share the link for the very first webinar that was presented in this series. And it was Dr. Herman Taylor, who leads the Moyo project, and Thomas Cotton, who's a member of our board, who is among the advisors for the Moyo project, which is designed to create skills and job readiness surrounding app development for for adolescents and young adults. But these apps are designed to be health promoting, specifically with a bent towards cardiovascular health. And so initially, Dr. Taylor, who leads the Cardiovascular Research Institute, presented with his colleagues at a CCB meeting, I want to say back in 2013. And because what they shared and their intentions were aligned with a community health needs and assets assessment that we do at least every 3 to 4 years through the PRC, which identified youth leadership as important because, as I shared earlier, we actually ensured that our core research project was focused on youth. So that was aligned with our mission. And then, of course, with the advent of mobile technology, we certainly wanted to be a part of a movement towards job creation through app and code, through app development, which we know is important. likely people will be attracted more to something that is related to something they care about, not necessarily in solely participating in a research study, but if they're getting marketable skills, it's valuable as well. So you can certainly pull up the details related to Moyo, but Thomas Cotton, given his tech interest, among many other things, he was among the advisors for Moyo, as was Lashawn Hoffman, and Russell Hobson, among a few others. So as that movement has evolved, and it wasn't always grant funded, we have evolved to serve as key advisors in that movement of having youth at the helm of developing apps that are health promoting. And that work is still in progress. Anything else you want to say before we leave this slide, Lashawn?
No, I think that could give the participants a kind of a scale of how we've been able to scale in our reach and our relevance in our work.
Yes, yes. So we have learned and evolved over time to be certainly the board being something that certainly keeps the PRC accountable, but our reach is well beyond the Morehouse School of Medicine or PRC affiliated researchers, but also now is governing many other infrastructures. So one example of this includes the Atlanta Clinical and Translational Science Institute, which was funded by the NIH beginning in 2007. It was funded for about 10 years, and the Community Engagement Core was at the time the only core of this alliance that includes Georgia Tech, Morehouse School of Medicine, and Emory University, that was led by Morehouse School of Medicine because of the leadership, not of the faculty and staff, but the leadership exemplified through the Community Coalition Board to really govern and provide a body through which investigators and community leaders could come in and present, get feedback, and support towards developing or sustaining community engagement. So the PRC Community Coalition Board model literally was adapted to then govern the ACTSI. So it included a community majority steering board with bylaws that were adapted from the prevention research centers to be relevant across the partner schools, and for investigators that certainly were not only at Morehouse School of Medicine, but now included 3 partner institutions. And through this partnership, the steering board governed the work of the Community Engagement Core and has scaled again. So back in 2016, the decision was made that to get this clinical and translational science work scaled more broadly, we would become a statewide initiative that's really designed to make sure that researchers are talking, but also to make sure that research is translated into where the disparities can be addressed, whether it's through approaches that get implemented in health departments, YMCAs, whether it changes the ways that researchers work together through approaches that make a difference, but also through advancing the art, the science, and the practice of community engagement. We want people to see our community engagement function as something where they don't just come to get advice, but we want them to learn how to do it. And so the slide that I'll share next shows exactly how the work that we've described so far has now been integrated beyond the adaptation of the PRC's Community Coalition Board to this statewide community steering board, which includes partners like the State Office of Rural Health, the Department of County Commissioners, among many others, a few of which actually are members of the Prevention Research Center. So as you can see here, we have 3 tiers of engagement that, as we've evolved, we've learned to really classify what those tiers are, similar to what Lashawn and I just presented on how we've thought through each of the iterations of our support to investigators over time. So just like the Community Coalition Board, folks can come, as you see in Tier 1, and present their ideas or concepts. And then we may decide that they...
Mr. Hoffman, I think Dr. Akintobi may have had a poor connection. Can you please proceed?
Sure. I was wondering what happened. So we wanted to kind of share a few lessons learned based on some of the conversation, some of the suggestions that you provided. And I mean, it's really clear, right? Community partnerships are not built overnight, and that there has to be a trusting partnership that's developed over months or years in order for partnerships to be sustained. And I've said this already, but it's not dependent upon a single grant or even the succession of grants, right? That it needs to be a partnership that is strengthened and developed regardless to if there's money that's available or not. Partnership means that resources and controls are shared. Community representatives should be primarily people who live in the community, and that partners and knowledge should be changing regardless of what happens in the shared. So tips and reflections. How do you develop a governing board composed of community partners and others? I think as we have evolved and take my word from it, our board has grown and has changed and has stretched. What we realize is that you have to get partners that have a shared interest of one in service, one that is with individuals that don't mind sharing, with community partners that have a vested interest in the communities that you're serving. Another tips or reflections that we had when we were putting this together is that you got to have your finger on the pulse. And so Dr. Akintobi shared with you earlier that every 4 to 5 years, we do what's called a community needs asset assessment and asset. I think I got that right. Every time I think about that, y'all, I get the words mixed up.
We say CHNA squared,
Right.
Community Health Needs and Assets Assessment.
And it's labor intensive, but at the end of the day, what it allows us to do is to really be able to say that we have surveyed community, we have listened to community, we have heard what the community has to say, and these are the top issues that communities are dealing with when it comes to health disparities in our neighborhoods. It also allows us to prioritize our work and say that if we wanted to think that, for instance, well, I don't have to give you for instance. We understand today that STI, sexual transmitted infections, are still a huge issue for our community today, right? But also what has bubbled up is diabetes and obesity and cardiovascular issues. And we don't have to guess at those things because we have surveyed the community, we have shared that community, but also this information that we've collected, we've given back to community partners so that they can use this as well to help combat some of the health disparities that our communities are going through. So it isn't just kind of information that we've collected for the sole use of the Prevention Research Center, but it is information that we've collected because we've always said this is the community's information. Now, how do we give it back to the community in a way that they can use it? Because we believe that more hands help to lift the heavy load. And then we like to kind of determine how the data will be used and should be used. And Dr. Akintobi, you want to jump in that one?
You know, the history of unfair, unequal, and inhumane treatment of underserved populations in research requires for, as Lashawn talked about, all of the other issues above, that what we co-create by way of data and information and how it's used should be discussed, and decisions should be made from the very beginning. So the least we do is give the data back, but even how we share it by way of news briefs, scholarly articles, Among many other things, we actually have a committee, a data monitoring and evaluation committee that is co-led by a member of the board and a member of our faculty to look at and decide how the data will, all of the data will be used, how it's packaged and how it's analyzed and given back, and how that data will guide even the type of funding we go after. We don't do it in a vacuum or based on what I studied in college or in my dissertation. It is based on what we decided from the beginning. So I think that's really important that those discussions happen early.
So we've received a couple of recognitions. We've contributed to the scholarly journals. We've celebrated in partnership, and we're really excited about this. I think what we wanted to leave you with as we get ready to kind of conclude our presentation is that for Dr. Akintobi and I think because we've been in this for a little while, right, this has become our natural progression to our relationship. And we realized when we were putting this presentation together, how do we share kind of what we have kind of becoming is that we have known is kind of our culture. How do you put that on paper to share with others? Everyone keeps asking us and have asked us numerous of times of, well, how do you do what you do? And I realized that partly we can put some of that on paper. The other dynamics is really about service to people, right, and being in relationships. And so I think if there's anything that we wanted to leave you with is that in any relation, any partnership, right, you have to have a good relationship. And we want to leave you kind of with these words of our chair emeritus. She would always say, research is good, but what can you do with the research after you get it, right? And I think we always kind of lead with that, you know, people bring great projects, but what do we do after we get it, right? And so we're really excited about the service that Mrs. Trammell gave us, her time as serving on the board and as our chair.
We are now open for questions. The webinar resources are available for download and the webinar presentation is available for download. Additionally, the contact information for Dr. Akintobi and Mr. Hoffman can be found on the screen. So Dr. Akintobi, we have to start with some of the, Dr. Akintobi and Mr. Hoffman, excuse me, we have to start with the hows. So how do you, if you are a community group searching for an academic partner, how do you engage in those steps? And if you are an academic institution searching for community partners, how do you initiate that relationship?
So Lashawn, if you're okay with going first from your perspective,
I think from a community perspective, it's important that some time is spent prior to seeking out an academic partner is to ensure that you have what your community values and priorities are, and how you would like to be in relationship as a community with this academic partners. I think those things have to be established, written, and presented up front, because I think that can be used as kind of your monitoring or your evaluation tool as you're going to speak with academic partners to ensure, do they align? I think so many times what happens is that communities and academic partners are in relationships, but haven't thought through kind of what's that mutual benefit that both of them can win between that. And I think that's why some of the partnerships aren't sustained over longer periods of time.
I think from the position of an academic, I would, and we didn't get into all of that, but when you go to our website and see some of our information, you'll see the history behind how this started, which I think still is relevant, and that is to identify existing community organizations or leadership groups within your city or within the spaces where you're thinking about doing your work. You don't have to develop necessarily a coalition board, at least in the beginning. In the very beginning, capitalizing on existing leadership and getting on their agenda, and I don't mean that literally making sure you're on their agenda, but finding out, and some of this you might do through Googling, but actually going to meetings, not to present, but just to sit and listen, to find out what they value, what is on their priority list, and taking the time to digest that and figuring out what that first meeting should look like based on what they care about. You know, again, as Lashawn said, relationships that last are about figuring out what the other party cares about and making sure that it is aligned with what you may value and seeing how it can be made attractive for them. So listening, seeing what already exists and not reinventing the wheel is important. And listening before you present what your priority is, listening for a while.
Thank you. It is now 3 o'clock, but Dr. Akintobi and Mr. Hoffman, would you mind if we take a few questions? So again, for webinar attendees, the webinar, wonderful, webinar resources are available for download. Webinar presentation is available for download, and we will have a few more questions for Dr. Akintobi and Mr. Hoffman. Our next question comes from Dr. Underwood, and he asks, how do you tie community prevention activities to patient outcomes, particularly for cardiovascular disease such as blood pressure reduction initiatives or stroke initiatives? So how do you tie prevention activities to patient outcomes using CBPR?
Sure, certainly. I'll give you an example, and certainly please feel free, Dr. Underwood, to reach out to me directly so you can get more information on this project that actually brought together the Department of Family Medicine with the Prevention Research Center about 6 years ago through funding from United Healthcare. The intention was to develop what's called a patient-centered medical home and neighborhood. And through data analytics that were provided through United Healthcare, we had that side of identifying a panel of high-risk patients in the East Point area, which is just outside of the catchment area of the Prevention Research Center. So we identified those patients, but we also worked to do an environmental scan or a community health needs assessment through our PRC to identify what health conditions communities lived with, and also what they knew about what a patient-centered medical home was and what their clinical experiences had been. The intention of bringing together our clinics and that CBPR process was to inform clinical staff about how to better serve and how to create this patient-centered medical home and neighborhood. And then it also resulted in the integration of community health workers within our ACO, or Accountable Care Organization, towards approaches towards addressing those outcomes. So in the interest of time, Dr. Underwood, please reach out to me and I'll share one of our first papers that's published based on that work. But I think it's a good example of how you can couple CBPR with an actual clinical intervention designed to advance health outcomes. So I look forward to seeing your note and sharing that example with you.
Thank you, Dr. Akintobi, and thank you, Mr. Hoffman. So one final question before your closing thoughts. And the question is, how do you give a voice to the needs of minority communities?
Lashawn, take it away.
How do you give a voice to the needs of minority communities? I'm not sure if you can give a voice. I think minority communities already have a voice. I think it takes great listening skills. So being present, going to community, hearing what community is saying as their needs are, and figuring out if there is something that you can marry, meaning research or other kind of opportunities that can marry with what their needs are, right, to start creating that partnership. I firmly believe that communities themselves understand some of the dynamics, but really need the help of others to kind of formulate those conversations or formulate the thoughts that they have, to be able to present them in a fashion so that others will listen to it. But I don't know if you can give voice to other minority communities. I believe communities understand the issues. Sometimes it's about helping them to articulate that in a way that attracts the resources that are needed.
Thank you. And now I will ask you, Dr. Akintobi and Mr. Hoffman, for your closing thoughts.
We have used the term flipping the script, not so much today, but flipping the script when we think about, even things like the last question, which I think Lashawn so eloquently responded to, and that is, how do we give community a voice, right? It requires us making space for all of the voices that matter. And we have made it a priority that community voice should not just be token at the table, but should be central to our approaches. And it has required us as academics to step back and hold ourselves accountable through structures like bylaws that flip the balance towards community voice being not only heard, but being prioritized. So I'll stop there, and certainly you can get much more information through our emails and our website.
So I just want to thank the participants on the webinar today. I think this has been really interesting, and I apologize for the technical difficulties, but that's life, right? So if there was something that I would leave you with, it was really be around this notion that everyone at the table has value. And I think sometimes what ends up happening is when community and academics come together, that either one party feels that they have more knowledge or value than the others. And I think establishing that everyone has the same value, but people bring different strength and skill sets to the table up front really allows for partnerships to grow, to be strengthened, but projects themselves to be thriving and successful. And so I just want to remind people that when creating partnerships, make sure that you take the time out to ensure that everyone that's at the table is valued, and that you understand the key strengths and skill sets that everyone brings to make the project great.
Thank you, Dr. Akintobi and Mr. Hoffman, for a highly engaging and informative presentation. And we thank each of our webinar attendees for spending your afternoon with us. We invite you to complete the series. We have parts 4 through 6 remaining, and by clicking the links on the presentation or by downloading the presentation from today's webinar, you will have access to register for the remaining parts. On behalf of the Morehouse School of Medicine Prevention Research Center, we thank you for attending today's webinar, and we hope that you have a wonderful afternoon.
Thank you, Shirley.
Thank you.